All right, so hello everyone. I am Dr. Deva Boone from the Southwest Parathyroid Center, and today we're continuing our parathyroid education course. Tonight I'm going to be talking about a more advanced diagnosis talk. So we're going to go over borderline cases and confusing labs. Last week we talked about normocalcemic cases, which actually consist of a lot of cases that people might find confusing. I'm not going to cover those as much tonight because I want to get into stuff that we haven't covered. All right, so got a few people here. I don't expect as many people at this one because it is a little more of an obscure topic, but this will be posted on YouTube after this, so you can always go back and watch it there. If you missed the normocalcemic one, go back to YouTube and watch that one as well. Okay, so let me switch to some slides. Okay, here we are. So advanced cases, borderline cases, and confusing labs, part of advanced diagnosis. All right, so first in this, I went through all of my previous cases over the last couple of years, and I looked at the ones that I called borderline or diagnostic. I'll explain why I called them diagnostic cases. So I looked through that and how I classified them and went through what I referred to as borderline or confusing cases, and then kind of was able to categorize them here. So first, as I mentioned, normocalcemic, most of the time this is not really that confusing. A lot of normocalcemic cases are secondary hyperparathyroidism, as I mentioned before. But you can have primary hyperparathyroidism, and sometimes it is confusing in figuring it out. I take a very systematic approach with these cases, and again, if you didn't see it, just go back and watch the talk on that because I cover this in great detail, how I deal with normocalcemic. All right. Next, so beyond normocalcemic, I'm not going to talk about that anymore because we covered it so much. These are the cases that I would truly call borderline. So the number one instance that I called borderline was when someone had intermittent high calcium. So they're not normocalcemic, but they're normocalcemic most of the time. When you check their labs, their calcium levels are almost always normal. But every once in a while, you get a level that is high, and it's not just one time, it's multiple times over a couple of years. You'll see calcium levels, say for an example, you have a middle-aged woman, her calcium levels are all in the 9s, but every once in a while, she's got a calcium of 10.4 or 10.3, something that is too high for her age. So how do you approach this? Well, you approach it like everything else. We're going to check a calcium and a PTH level together. But the most confusing cases are when you can't catch the PTH level with a high calcium. To diagnose primary hyperparathyroidism or any parathyroid disease, remember, we want to see the calcium and the PTH together, and you want to see the relationship between those two. So if you have a high calcium and a high or normal or high normal PTH level, then that's diagnostic for primary hyperparathyroidism. With some of these cases with intermittent high calcium, the problem is that there is high calcium, but it occurs infrequently. And when you check it again, the calcium is often normal. When you check it again, you may get a calcium and PTH together and everything looks normal. With these cases, a lot of them will be primary hyperparathyroidism, and they will develop into more convincing labs with time. So I always look back at their lab history. If they consistently always had normal calcium levels up to 3 years ago, and now they've started having these intermittent high calcium levels, a lot of times that just means early parathyroid disease. That is kind of classic, where in the first few years you see these intermittent levels, and then over time you'll see it stabilize and have continuously high calcium after a few years. Some people go high immediately and stay there, but a lot of people will have these levels bouncing around for a few years, and then finally it will go high. But I also have patients that have intermittent high calcium that just continues for years and years, and it is not exactly clear why. So that's the first situation. In some of these cases, and I'll go over kind of how we then deal with this or get to a diagnosis in a second, but these are very common cases that I call borderline. When we have this intermittent high calcium, PTH level may or may not be checked with the calcium. It's not really clear what's going on or what's causing the high calcium. Note that one of the first things I do is check a vitamin D level, because vitamin D can give you these intermittent high calcium levels as well, or vitamin D supplementation. Okay, the next most common scenario is a high calcium, persistently high, but with a low normal PTH. Now, I said for primary hyperparathyroidism, the main diagnostic criteria is a high calcium and a normal or high PTH level. You don't need a high PTH to diagnose primary hyperparathyroidism. That is very clear. All you need is an inappropriate PTH level for the calcium. So if your calcium is high, a PTH level that's, quote, normal range is inappropriate for it, and that would be diagnostic for primary hyperparathyroidism. But there is a gray zone here. So for people who have high calcium due to something else, for example, there are cancers that can cause high calcium. What you see with that when you have a cancer that's causing high calcium is you have a very low PTH level. Not just low normal, but typically very low. In the suppressed range, we're talking single digits PTH, very low PTH. Okay, and when you have primary hyperparathyroidism, usually what we're seeing is normal or high-ish normal to high PTH levels. The gray zone occurs where you're not in the suppressed range, but you're also still very low. So PTH levels in the 20s and 30s in picograms per mil, all right? 20s and 30s. What I'll see is somebody will have calcium levels that are continuously high. They're in the 10s, but their PTH levels are in the 20s, and they stay there over time. We recheck them. They've been checked multiple times. They're always in the 20s. This is very unusual for primary hyperparathyroidism, and it doesn't look like the situation where something else is causing the high calcium. For example, it doesn't look like cancer, because that, again, would produce very low PTH levels. It doesn't look like that. It doesn't look like primary hyperparathyroidism, though, because typically we're going to see higher PTH levels, not low normal. So this is another common scenario where I look at this and I'm not completely convinced that it's primary hyperparathyroidism off the bat. This is another one where I will check vitamin D levels immediately, because this is kind of the classic picture you get with over-supplementation of vitamin D. If you're on high doses over a long period of time, especially, you don't even need to have a toxic level of vitamin D, but you can see these high calcium levels and low-ish normal PTH levels in the 20s and 30s, and that is high calcium from the vitamin D. But sometimes people aren't on vitamin D, and it's not clear what's going on. All right, another common one is high calcium, but a low urine calcium. Okay, most people with primary hyperparathyroidism have a high urine calcium, or at least high normal. But you can have a low urine calcium and have primary hyperparathyroidism. It's just not the most common scenario. So if you see a really high blood calcium, but a very low urine calcium, like below normal for what a urine calcium should be, that could indicate something like FHH, which is familial hypocalciuric hypercalcemia, which is a lot of words just to say that you have a genetic condition that causes high blood calcium and low urine calcium. And that is the syndrome. That's FHH. So if I see this picture, I might be thinking maybe this is FHH. And we'll get to how we establish that. Another borderline situation, high calcium for many years. So most people with primary hyperparathyroidism don't come to me immediately when they're diagnosed with high calcium. That's not the common scenario. Usually they have several years of high calcium levels before their doctor flags it, before their doctor tells them it's a problem, before they get referred to a specialist. So it's really common to have high calcium for several years. If you've had high calcium for decades, like you tell me, I've had high calcium since I was 20 years old and I'm 60 now, that's kind of a red flag. That would be very unusual for primary hyperparathyroidism. It's not impossible. You may have had primary hyperparathyroidism that time, but it would be extremely unusual to be present for so long without you having, for example, a ridiculously high PTH or really high calcium by that point, or really severe consequences from the disease. So you've had high calcium for 40 years, but you've been doing fine with it. Little unusual or very unusual for primary hyperparathyroidism. So that makes me wonder, is something else going on? So how do you make the diagnosis? It's not impossible. With these cases, I go through systematically, just like with normal calcemic. You want to go through a checklist of things to try to figure out what's going on, to try to uncover what the actual situation is. So first, I'm going to get more labs now. This is going to include vitamin D. That's going to be essential, but rechecking the calcium and PTH. Sometimes with this intermittent high calcium, they just haven't had a PTH checked enough or at the right time, and getting more labs will show us that. So I'll say to somebody, okay, we're going to get labs for the next 2 or 3 weeks, 1 week apart. We're going to get calcium, PTH, vitamin D, and then recheck the calcium and PTH, and then possibly recheck it again. And we should see things fluctuate. If the calcium's kind of going up and down, I want to see what the PTH is at each time point. And I should be able to make the diagnosis from one of those time points. Now, if everything stays perfectly normal during that time, I still may not be able to make the diagnosis, and then we need to check over a longer period of time. But first thing is check the labs. Make sure you're not overdosing yourself on vitamin D, because again, even if you're not in the toxic range, you could still be causing your calcium to be high if you're on high dose vitamin D. And I consider high dose to be 5,000 units a day. I have seen even lower doses cause it if you've been on it for a very long time, because it is fat soluble. It's a hormone. Remember, it's a hormone that's fat soluble, that will be stored in your body over time. And so it can build up to higher levels the longer you're on it. Okay, get prior labs. This is often essential. So I will tell people to go back and get as many prior labs as they can. I know this is hard and sometimes impossible, but if you've been going to Sonora Quest, if you've been going to Quest Labs or LabCorp, they often have a patient portal and they may have stored it. So go into your portal, see if you can find old labs. Your doctor may have them if you've moved around, and a lot of people have. They've seen multiple doctors. Those labs are lost. But if you can, they're really helpful. Because again, if I see that your calcium level has been high for the last 20 years, that changes how I'm going to think about it versus if your calcium was normal 10 years ago and 8 years ago and 7 years ago and only 4 years ago did your calcium go high. That's very suggestive for primary hyperparathyroidism. A calcium that's been high 40 years points against primary hyperparathyroidism. Check a urine calcium. So for some of those scenarios, we may not have a urine calcium. You've had high calcium for 30 years, or maybe your calcium's kind of bumping up and down, but it's been kind of consistently in the high 9s to low 10s for the last 10 years. I want to check a urine calcium. It's going to be important in these borderline cases. For most cases of primary hyperparathyroidism, I don't need a urine calcium. For anything that's borderline, I get a urine calcium. What does this tell us? Well, if your urine calcium is very low and you've had high calcium for 10 years or longer, that's when I'm thinking about FHH, right? Rare syndrome, but it does happen. And I see these patients and I can diagnose it. The way to diagnose it actually really is to get genetic testing. So for all these patients, if I get a high calcium level and a very low urine calcium and I'm suspicious of FHH, I will order genetic testing. And that's done through a mouth swab that you can do at home, mail it back. Takes a couple of weeks, but we can get pretty good answers now. There are 3 genes currently, 3 gene mutations currently that we know of causing FHH, and I'll check all of those. There are likely more because there are patients I know that they likely have FHH, but we can't prove it because I've checked the 3 genes that show it and they've all been negative. So there are likely ones that we don't know about, but we will discover with time. And actually we've discovered these only in recent years to get all 3 of them. Okay, family history. So again, thinking about FHH, most people with FHH are going to have family members who also have high calcium. And they may not have mentioned it to you. So I ask people, are your parents alive? Do you have siblings? Has anybody mentioned high calcium? And then if people are still alive, go and ask them. Actually go and ask, have you ever had issues with calcium? Because your sister may know that she's had high calcium for decades, but hasn't thought to mention it because it hasn't affected her life. Her doctor told her it's just her normal, and she's gone about her life. So I have had situations where once you start asking, actually all the siblings have high calcium, and nobody was really talking about it. People weren't having an issue with it. But now that we know, it really does look like a familial hypercalcemia syndrome like FHH. So I tell people, I have them go and ask their close family members if they've ever had a high calcium. Genetic testing is the next step. And this is really for anyone that I'm suspicious of. So even if your urine calcium was normal, even if your family history, even if nobody reports having high calcium, sometimes genetic testing is still necessary just to rule that out, because there are cases of it happening spontaneously. You get a spontaneous mutation that nobody else in your family has, and now you've got this familial hypercalcemia, which is not familial. Nobody in your family has it, but it is a genetic condition. So I will get genetic testing for anyone where I'm thinking this is possibly it, if the story is not quite adding up. Okay, imaging. This is a big topic, and I debated whether I should put this on here. That's why it's in parentheses. Imaging is not used to diagnose primary hyperparathyroidism. Full stop. That's just how it is. We're not using imaging to diagnose primary hyperparathyroidism. We use labs. But when you have somebody who is where it's unclear, where the labs are borderline, where you're not sure, there are a couple of things that you can do, and one of them is operate and look at the neck. But not everybody wants to jump into an operation without knowing something or having some other clue there. Imaging is one piece of information that can be a clue. So I've had patients where their labs are not clear. They're borderline. The PTH is 20 always, and the calcium's always high, and it's only been high for the last 5 years, so it kind of looks like primary hyperparathyroidism, but the PTH is puzzling. And we get a scan, and they've got a big tumor showing up on scan. Not the most common scenario, but I have had it happen. And so it makes sense if you're kind of not sure, if you're, if you don't want to operate yet because it's not clear, just get the imaging. If it's negative, great. It doesn't really tell you much, right? You can still have a parathyroid tumor with negative scans. But sometimes you have a really obvious tumor, and then you can say, okay, well, look, we know we have this thing to go after now. We're not making the diagnosis based on it. The diagnosis is based on labs, but it does help us with the decision to go to surgery, especially because a lot of people don't want to just get their neck cut open just for getting a diagnosis. But some do, and that is the final step. Final step is a diagnostic operation. So I do these. It's, usually I know what the diagnosis is, but in some cases, if I still can't make the diagnosis after all of this, so we've gotten more labs, still not clear. We've looked at prior labs, still not clear. Urine calcium is borderline. Genetic testing is negative. Nobody in the family reports anything. Imaging is negative. But the patient still has these high calcium levels and they're having symptoms and they have osteoporosis and they're possibly getting kidney stones. Well, the way to figure it out definitively and to treat it is to do an operation. So in these cases, you go in there with the goal of finding all 4 parathyroid glands and removing any abnormal ones that you find. Unless you find hyperplasia, in which case you don't want to remove all 4, but you can remove 3.5. That's a separate talk. But you're going in there really to make the diagnosis. It's a diagnostic operation. So I do this. It's not uncommon, actually. So I get a lot of patients that have these more borderline cases where we just can't figure it out and we go forward with an operation. And I wouldn't do an operation if I thought there was a pretty good chance we're not going to find anything. So if I really strongly feel like this looks like a familial hypercalcemia, maybe we can't prove it, but the story is pointing towards that, I will tell people, hey, it's not certain. I think there's a chance we're going to find something, but it's up to you what you want to do. I like to have at least a 75-80% chance in my own mind that we're going to find a parathyroid tumor. In order to operate, I want to do cases where I think we're actually going to help you, but there are cases where I am genuinely not sure what I'm going to find. I go in thinking that possibly I'm going to find 4 normal glands, and that's okay. It's okay to do a diagnostic operation, to go in there, look and find normal glands, because that does at least get us one step closer to the answer. It may not be the answer you want, and certainly that we all want to be able to fix the problem, but at least going in there and being able to confirm that there isn't a parathyroid tumor is useful in itself. So diagnostic operation is the last step. This is kind of a one-time thing. So even if you don't find all 4 parathyroid glands, and sometimes you can't, sometimes it's not possible to find all 4, and that can be for multiple reasons. Sometimes you've got a normal gland sitting way down in the chest. You're never going to see it on scan, and you're never going to see it in the operating room unless you're opening the chest, which you're not going to do unless you have something to go after. So there are cases like that, but you really want to give one shot to find all 4 glands and look in all the standard locations around the thyroid in order to find those and make sure that you're not missing a parathyroid tumor. And people ask what I do once I'm in there. If I find all 4 and they all look pretty normal, well, I'm going to just hedge my bets. I'm going to say, well, what are the chances? Maybe there's one that's not normal. Maybe it looks relatively normal in size, but it's not normal. So I will carefully look at all 4 multiple times and basically figure out, is there one that's larger? Is there one that looks just not quite right? And I'm going to take that out. I'm going to take out at least one gland that doesn't look like the others, because rarely are they all exactly the same size or exactly identical. You will find some variation in there. So I'm always going to go in and think, I want to make sure that I'm leaving in only perfectly normal parathyroid glands. I don't want to risk leaving in a tumor. So that's what I'm going to do during a diagnostic operation. And for the most part, at that point, you can answer the question. I have had people, get a diagnostic operation and then at a later date find that they've got a genetic mutation. For whatever reason, they couldn't get genetic testing before. I've also had people, like I said, where I do a diagnostic operation, I find 4 pretty normal glands. Genetic testing was all negative, but those patients, there are some patients I am convinced have a familial hypercalcemia that we just don't have the gene figured out for yet, because their story really looks like it. They've had high calcium levels forever. I go and look at the parathyroids and all 4 are really normal. I take out the largest 2 glands, leave in tiny parathyroids, and afterwards the labs are completely unchanged. So that can happen. I think that's everybody's biggest fear when I operate, is that I'm not going to find anything. it's a very rare occurrence for most patients. If I even offer an operation, it's because I think there's a pretty good chance. But if we're doing a diagnostic operation, I will make sure that you know that you know that, we're going in there and I'm not sure what I'm going to find. But the goal is to figure it out and answer the question definitively. That's the goal. All right, so good timing there. Hold on. I'm going to switch back to my camera. All right, so with that, I can go over the questions and comments. Yeah, if you have questions, let me know. We've got lots of time, so I can answer everybody well. All right, so Rachel Kinney says, curious, do you know what it means having a low end alkaline phosphatase before surgery and after surgery? And does that affect bone remineralization after surgery? Interesting question. So normally, most people with primary hyperparathyroidism have normal or elevated alkaline phosphatase levels because you see bone breakdown. Basically, you'll see an elevated bone alk phos level. And alk phos, just so everybody knows, when we're checking it normally, it's part of a liver function panel because alkaline phosphatase is also released by the liver. So if you have a lot of alk phos or an elevated alk phos, mostly what we think is, oh, that must be the liver. But alk phos is also released by the bone. So patients with primary hyperparathyroidism will get an elevated alk phos. The lab that we check normally doesn't distinguish between bone and liver alk phos, so you have to check that separately. But when you do, usually with primary hyperparathyroidism, you'll see that it's actually the bone alk phos that's elevated and the liver is fine. What does it mean having a low alk? I'm not sure what that would mean, and whether that would, I'm not sure we have studies on that, whether that would actually affect bone remineralization, because if your alk phos is already on the low end, we may not see the same improvements, but actually I don't know. I mean, it's a good question. I'm assuming that your alk phos was a little bit on the low end. I don't know if it would affect it. You'd probably want to check bone turnover markers. If you're actually concerned about bone remineralization after surgery, it's a good idea to check the bone turnover markers before and after surgery. And those are it's CTX and the P1 and P are the main ones there. And they're a little bit better for giving you an idea of what the bone status is and what kind of bone turnover is occurring. So I don't know that alk phos is the best thing to be looking at there. Okay. All right, so Liz says, hi, Dr. Boone. I had surgery in March 2025. All labs are normal except the calcium is still a little low. I have increased barium amounts to 3 a day. My calcium was 7 after an adenoma was removed, which is very low. Calcium is 8.4 before taking the additional barium each day. We'll get the calcium recheck December 22nd. What calcium number should I try to increase to? Feeling much better, just concerned about getting a secondary hyperparathyroidism. Yeah, thank you. So yeah, I mean, it is, this happens after surgery, so where sometimes the calcium is just kind of on the low end. It's usually good to also know what the PTH level is, so to know, are your parathyroid glands responding appropriately or are they not responding appropriately? If your PTH level is on the higher end, then the parathyroid glands are responding appropriately to that calcium level. If they're not, then it indicates that your parathyroid glands still are having trouble making enough PTH. So it would be helpful to know that, but it's not uncommon to have these levels be on the lower end and to need a little more calcium. Barium amounts, so 3 a day is really not an excessive amount. That's 750 milligrams. So it's more of like a dietary supplementation level at that point. I'd like to see calcium levels in the 9s. So that's where most adults are going to naturally gravitate to, the mid to high 9s, but some people are in the low 9s, but I really like to see it in the 9s, not in the 8s. You're not on a lot of calcium, so I would have just increased straight away to something like 4 a day or even 6 a day temporarily if you were 8.4, and then rechecking. But that's what I would do. The getting secondary hyperparathyroidism is not as much of a concern. I mean, a lot of times with secondary, it really is just an indication that the parathyroid glands are doing their job, and you will be able to calm them down just by taking more calcium. It takes a really long time for secondary to become to the point where you would need surgery. So right now, I would just take the calcium. Oh, you said that PTH is in the middle of normal. Yeah, well, that's good. So that's good. It just looks like you need a little more calcium, and that's not unusual after surgery. I would increase. You probably need more than just the 3 berry melts a day, to be honest. Probably at least 4, but we'll see what it is soon. Mary asks, what does ectopic parathyroid, or I guess you mean what does it mean or what is it? Ectopic just means a weird location. So if you have an organ in an ectopic location, it means it's not in the normal spot. Parathyroid glands are actually the most common organs that are ectopic, that are in weird spots. And actually the term is probably a little bit overused. The way I use ectopic is if it is outside the normal areas where I find parathyroid glands. So most of the time I can find all 4 parathyroid glands in this area, around the thyroid, behind it here, and a little bit below it. Those are the areas where it's very common to see parathyroid glands, where I just call it normal. Ectopic is outside that range. So up here, in the carotid sheath up here, that would be ectopic. That's not the normal location for a parathyroid gland, but it happens. And then down in the chest. So if you have thymus that extends down into the chest, if it's way down there, that's ectopic. In the thymus, but right below the thyroid, is a common location. But in the thymus, way down, near the heart, that's not common. That's ectopic. So that's what ectopic means. Marcella says, I have 1 parathyroid left after 2 surgeries. I'm not taking calcium supplements as advised. My question is, will 1 parathyroid suffice for a correct calcium level? If it's a normal gland, then yes, it should, if there's enough remaining. Now, parathyroid glands do vary in how large they are, and I've seen parathyroid glands that are fairly tiny, and I think to myself, I wouldn't trust that gland to work on its own. So I don't want to leave just that gland in. So I have been in that situation, but for the most part, 1 gland is fine, because you don't need an excessive amount of PTH or an excessive amount of parathyroid tissue in order to regulate your calcium. You need a small piece that can make enough of that hormone, and 1 gland is typically enough to do it. But it varies. I mean, you'd want to see what your labs are, but if you're not taking calcium and you're doing fine, then it looks like that parathyroid gland is doing its job. And if it wasn't, you would know, because you would need to be on lots of calcium. Okay. Maya says, I had diagnostic operation and 2 glands were found and removed. It was hard to diagnose, and I did choose for that reason. Yeah, these are tough cases. And hopefully your labs are now normal, but that is a common scenario. It's just very, very hard to figure out sometimes without an operation. Okay. Stephanie is sending another patient. Thank you. Wanda says, can you live a normal life without medication, without 1, 2, 3, or all 4 glands removed? So I'm not sure what you're saying. So can you live a normal life without medication, meaning if you don't have surgery but have primary hyperparathyroidism? If that's the question, yes, some people do okay with having primary hyperparathyroidism. It's not the most common thing, but there are people who have it and don't have symptoms, and they feel pretty good. They don't get surgery, and that's it. I mean, they live their life. Now, with one gland removed or two glands removed or three glands removed, yeah, you live a normal life. I think that might be what you're asking is, do you need all four? You don't need all four. One gland is perfectly fine as long as it's a good chunk of parathyroid. Now, there's a difference between, though, having 3 glands removed and having 4 glands removed. If all of your parathyroid glands are removed, you're not quite going to have a normal life without medication, because your parathyroid glands are really essential for regulating your calcium. And if you have no parathyroid tissue, like none, it is very hard for you to regulate your calcium. So you end up taking a lot of calcium, a lot of vitamin D, and then prescription vitamin D, which is called calcitriol. You end up taking that, and you end up taking a lot of calcium in order to regulate your levels. Now, we also do have an injectable PTH, which is a daily injection of parathyroid hormone that you can use to help live a normal life. But again, that is a medication. You have to inject it every day, but that will help you replace that PTH and live a much more normal life. But yeah, you don't want to have 4 glands removed. 3 glands removed is pretty much the same as having 1 gland removed, as long as you've got that one remaining. Okay. Dawn asks, what is the point of doing a biopsy and a normal parathyroid? Great question. I wasn't planning on getting into this until we talk about the operation, but here's what it is. So when I operate, when I was trained to do this operation, I was at the Norman Center, as most of you know, and we biopsied all glands, normal or not. So take out the parathyroid tumors and biopsy the other glands. I have moved away from that somewhat because the risk is very low when you take a biopsy of normal gland. But if we're talking about really tiny glands, sometimes you don't want to touch it. You really would just prefer to leave it alone because it's tiny, especially if it's the only gland you're leaving in. You don't want to screw with it if you're really counting on it working. And just doing a biopsy on it seems to maybe temporarily kind of stun it. So I have somewhat moved away from biopsying all 4 glands. If you get an operation with me now, it's much less likely that I will, but sometimes I do, especially if they're all big enough and they're, you can see them easily and you can take a tiny, tiny slice of it without damaging it. But if there's any chance that I will damage it, I don't touch it. Okay, so what is the point? Why would I do that? If I'm looking at it and I know it's normal, why do I biopsy it? Well, it's not to get the pathologic diagnosis, because pathology is weird for parathyroids. And really all it will show me is that there's parathyroid tissue. They will comment on the cellularity, and I completely ignore it because it's useless. When they comment on the cellularity, what that means is they're looking at it under the microscope and they're estimating the amount of cells to fat ratio. So a normal parathyroid gland has a bunch of parathyroid cells sitting in it, but it's all kind of surrounded by fatty tissue too. So there's lots of little fat cells floating around. A parathyroid tumor is going to be all parathyroid cells crammed together without much fat in it. That's a parathyroid adenoma. And then around it, you'll see more normal parathyroid tissue that has, fatty areas mixed in. When they talk about cellularity, they're talking about that ratio. So they're looking at how many cells are packed in together, versus cells with fat around it would be a lower percentage. But if it's 100% hypercellular, that means there's no fat. It's all this parathyroid tissue. Well, when you take a biopsy, you're taking a tiny sliver, and I'm talking tiny. The glands are the size of a grain of rice. My biopsy is barely visible. I mean, honestly, sometimes the specimens get lost because they're that tiny. So I have to be very careful about when I take it to put it on a piece of like a white telfa, and we have to carefully put it over because they're tiny. They're just the tiniest specimens. You're looking at a tiny piece of the parathyroid. Parathyroid cellularity varies across the gland. So certain areas of the parathyroid gland are more cellular than others. If I take a tiny piece of that one tip, of the ends, the poles, they're more cellular. So there's a pretty good chance that the pathologist is going to look at this tiny, tiny piece and say it's hypercellular, which doesn't mean anything. It doesn't mean it's hyperplasia. It doesn't mean it's abnormal. It doesn't mean there's anything wrong with the gland. That's just where I took the biopsy. Okay, so I'm not looking at pathology. I will say about 50% of the time, my biopsies of normal glands come out as hypercellular. So if that happens on your pathology report, don't worry, it's normal. Okay, but again, I'm not answering the question, right? Why would I do it in the first place? Okay, this is because the real answer is because most doctors are terrible at this operation. And I hesitate to say that because I'm normally kind of political about this, but most doctors who say they saw all 4 glands did not. And most surgeons, when they say I saw this parathyroid, they did not. How do I know? Well, before I went to the Norman Center, I worked with other surgeons who were doing this operation. So I do know what they're able to find and what they're not able to find. And these were endocrine surgeons that I was working with. And then also I do a lot of reoperations. So I do a lot of cases where somebody has had a prior operation and now they still have parathyroid disease and they need surgery. And in a lot of these cases, the surgeon will say they found a gland and it was normal. And if they didn't biopsy it, I do not believe them. I just don't. Because most likely they didn't find it. They didn't find any parathyroid. Because then I'll go back and I'll find the gland and it's a huge tumor. There's no way they could have missed that if they had actually seen it. So that's the point of doing a biopsy, is to prove that you saw it. That's it. That's really kind of it. So I do it and so that I can document, yes, these were seen. Now, then why don't I do it to all of them? Well, if I'm in there, right, and I take out a big tumor, or maybe I take out 2 tumors, and the other 2 glands are perfect and they're tiny and I can clearly see them. Well, I know myself that I know how to look at parathyroid glands. So why do I need to take it? Well, it's to prove to everybody that it was seen. So if they're both really tiny and I think, look, I don't even want to risk this, I won't do anything. But in a lot of cases, especially if I've gone to one side, so here's an example. You have one big tumor on the right side, and then a right upper, and then the right lower is also a tumor. You go on the left side, they're both normal. To document that I was on that side, I will usually biopsy at least one of those glands on the left side, because I have done, not a ton, but I've done operations where the surgeon says they went on the left side, both glands were normal. I operate on the left side and they didn't even go there. There's not even any scar tissue. So you have to do certain things to kind of prove, yes, this was done, this was seen. If I biopsy those normal glands, I can say, yes, look, here they were, and I know where they are because also in my operative note, I write where each gland is. Each gland that's remaining, I have a little blurb about where it is so that I can find it again. And I do that whether I biopsy it or not, but that's really for the benefit of anybody who is coming down the road and needs to go in their neck. They know where they are. And also, any surgeon that's going to go in the neck in the future knows, okay, yes, these glands were found and they were normal and they were recorded. So that's the point. I'll talk about it more. I know it's confusing and, it has to do with how other surgeons don't really find the glands and you have to prove it with a biopsy. That's kind of the main thing. And, if I find 4 normal glands, I will want to prove that all 4 of them truly were found, because sometimes I'm wrong. I've done this a lot, and most of the time I'm right. When I look at a parathyroid gland, I'm like, yeah, that's parathyroid, it's normal, whatever. But sometimes you're wrong, and some necks are very difficult to deal with. Sometimes the parathyroid gland is in a bad location. It's difficult. You do for yourself want to prove, okay, yes, all 4 were found. All 4 were normal. I don't need to go back and ever look for that gland again because it was found already. So especially in these diagnostic cases, a lot of times I will biopsy all 4 because I want to answer the question definitively. Did I find all 4? Yes. And hopefully they all kind of look normal on pathology, but that doesn't really matter either. It's how they look in the operating room, really. If I know that I've fully exposed them, and again, if it's a diagnostic case, then yes, I have. I've fully exposed it, made sure that I'm not leaving in a parathyroid tumor. Okay, this is a long answer, but we have time tonight, so. Okay, Kathy asks, how often is a parathyroid gland ectopic? Not that often. So can I give you exact numbers? No, it has been studied, but it also has to do with how you define ectopic. Ectopic glands that are down in the chest that are really high up under the neck, we're talking less than 1%, things that will change the operation. Glands that are in here sometimes are called ectopic by the radiologists. And I read the location, I'm like, no, that's actually a normal spot. It's not ectopic. To be truly ectopic, like in one of these areas where the operation would change, meaning, I'd need to make a separate incision up here or possibly going through the chest or going through the ribs to get to the thymus to get down far enough to get the gland. That is rare. That would be under 1%. Given the cases I've done. Okay. Ludmila says, my endocrinologist sent me to a surgeon after one set of tests. Calcium is 9.9, which is normal for any age. PTH of 43, which is normal. 24-hour urine calcium of 303, which is a little high. Osteoporosis and kidney stones since 22 years old. Vitamin D, 36. The surgeon stated it seems an inappropriate relation of PTH to calcium. Calcium and osteoporosis and kidney stones are enough proof to have surgery. Suspected hyperplasia to remove 3.5 glands. Ultrasound just noted non-toxic multi-glandular goiter. Do I have to do more test labs before I consider surgery? Okay. So I diagnosed primary hyperparathyroidism based on labs, primarily calcium and PTH. Your calcium is normal. Your PTH is normal. With just this set of labs, I would never recommend parathyroid surgery for someone with just this set of labs. Osteoporosis occurs for multiple reasons. The big risk factors for osteoporosis are being female, getting older, genetics. Can't change a lot of those, right? But parathyroid disease is one thing you can change, so we tend to focus on it. But really, most cases of osteoporosis are not due to parathyroid disease. It has multiple causes, most of them not parathyroid. Kidney stones, not enough evidence for primary hyperparathyroidism. Your urine calcium is high, and that's concerning, and that's likely why you're having kidney stones. But that does not say that you have primary hyperparathyroidism. If you have never had a calcium that is above 9.9, then I would not suspect primary hyperparathyroidism. Again, unless possibly this calcium was the one normal calcium you've had over the last 10 years, maybe, right? If you've had calcium levels of 10.5 and then we check one and it's 9.9, that's a different story, right? But if all your calcium levels have been normal and your PTH is 43, which is, low normal, which isn't true normal range, then I would not suspect primary hyperparathyroidism, and I would not recommend surgery, especially not removal of 3.5 glands, because if you're taking out 3.5 normal parathyroid glands, you are at risk for hypoparathyroidism. Your glands are not large. They're going to be fairly small. Remember, when I'm operating for hyperplasia, by definition, those glands aren't normal, and they're usually all a bit enlarged, if not massively enlarged, at least a little bit enlarged. So it can be safe to take out 3 glands and part of the 4th. If all 4 glands are normal, I would not feel comfortable doing 3.5 gland removal. That's all I'll say. Okay. I think I got the message across there. Okay. Nancy asks, let me see. Nancy asks, hi, Dr. Boone, do you ever recommend Sensipar? And in what cases would this be recommended? Are there side effects? I really do not care to have a 3rd surgery as my blood levels are remaining high-ish. You did my 2nd operation in August. Okay, so this is the case where I would consider Sensipar, is if you have had, multiple operations. I do recognize people's names, but for patient confidentiality, I never admit to knowing who you are, because to maintain confidentiality, but you're saying it out loud. Yes. So, yeah, if someone's had multiple operations and the calcium is still high, another operation is still an option. That's always an option. But if it's not clear where the tumor is, or if you just don't want to do it again, then Sensipar is an option. Sensipar does have side effects, and a lot of people can't tolerate it because of that. So the side effects that most people complain about the most are the GI side effects. So if you had GI effects like bloating, nausea, diarrhea, whatever, then you wouldn't want to take it. Some people just don't feel well on it. The other thing is that Sensipar is good at certain symptoms, but not others. So it can be very good at things like fatigue, brain fog. It can help with that. It tends not to help so much with bones or with bone pain. So it kind of depends on what symptoms are bothering you the most. But Sensipar is an option. Some people do just fine on it. They're able to get their calcium into normal range. And they feel better that way. And for those cases, I would say absolutely do it. It's not the first line therapy, but again, if you've had an operation that was not successful or a second operation that was not successful, then it is worth considering. Okay. Sorry, I lost my spot. Okay. Liza asks, if you have true hyperparathyroidism and remove the affected glands, can you become hypoparathyroid? Is that a risk? For the most part, no. It's not risky to leave in normal glands. They will almost always wake up and work and function normally. The risk is if you have to remove 3 glands and you're left with just 1. The risk of hypoparathyroidism is there. I want to say it's 0. I want to say no, that never happens. But I have seen cases where I take out the abnormal glands. I know they've got normal glands remaining, but for some reason the PTH does not seem to respond like I think it would. So it seems like there are rare cases, where the remaining parathyroid glands are not up to task. And this kind of gets into what I was saying earlier, where sometimes I go in there and a normal gland will be so small, and I'll think to myself, I wouldn't trust that on its own. So I think some people do have parathyroid glands that are maybe not up to task. Is that common? Absolutely not. This is not common. Most of the time, if you take out a bad parathyroid gland and you've got 3 glands remaining, you're going to be fine. If part of those glands are removed, or you take out multiple glands and the others are biopsied, and the biopsy is very large and it's taking out half the gland, or you're injuring the gland as you're working with it, then hypoparathyroidism is a risk, but it's low. But then again, there are these rare cases where I'm, see somebody who's hypoparathyroid and they shouldn't be. It doesn't kind of make sense. But their other glands are just not doing it. They're making PTH, but they're not making enough to fully regulate calcium. Okay. Nora says, if I miss the normal calcemic session and view it after the fact, is there a way to submit any questions I might have after viewing it? Yeah, so on YouTube, you can put comments. I'm not I don't do this. I don't go on YouTube a lot, but you can submit comments there. But also on my website, it's very easy to contact me. There's a contact email. So if you have a burning question, just email me or ask on YouTube, and I will eventually see it and answer. Or through Facebook, people message me through Facebook as well. So you can always comment here. Facebook now does remove all videos after 30 days. So you won't be able to see the video. I think it's only up for another couple of days, but I do have it downloaded. So I will be putting it on YouTube. You can comment there or comment through Facebook. Okay. Nora says, I'm taking hydrochlorothiazide for 2 weeks to evaluate for a potential renal calcium leak. I've also completed a 2-week calcium load, after which my PTH remained slightly elevated, lower than prior labs, but above reference range, and my calcium and 24-hour urine were essentially unchanged. Due to this duration and severity of symptoms, I am hopeful for a clear answer and a path forward. Yeah, definitely watch the normal calcemic talk, but I will say that these trials are often not necessary. In fact, they're rarely necessary. I start people on hydrochlorothiazide, but that's because I've already figured out that it's renal calcium leak. You don't need a hydrochlorothiazide challenge to diagnose that. You also don't need a calcium load challenge for nearly all cases. So I find it a little bit odd that you're doing both of those challenges. It seems a little bit weird. It seems like it's probably not necessary. It seems like if somebody really just evaluated your labs, they'd be able to figure it out without all of these challenges. But yeah, watch the talk if you have questions. Ask. And I'm doing this monthly, where I'm going over a different topic and doing a Q&A, so you can always come back and ask during the Q&A, like this. Okay. Alice asks, is there a link between hypoparathyroidism and neuropathy? Interesting. So hypoparathyroidism, hyper or hypo, really. So calcium is really necessary in brain and nerve signaling. So you do get neuropathy-like symptoms with hypoparathyroidism. Is it a true neuropathy? Not clear, but you get things like more numbness and tingling, cramping. You get all of these muscle and nerve issues with hypoparathyroidism because those things depend on having a normal calcium level. So yes, depending on how you define neuropathy, I mean, your nerves are still working, but they are not signaling as effectively or working as effectively with a low calcium level. Okay, Emma asks, after successful surgery, what is a time frame of feeling better / reduction in symptoms? I'm 7 months post-op and still experiencing bone pain. Is this normal? Okay, so it varies. It varies for everybody, unfortunately. And so it's very hard for me to say this is what you're going to feel. When people ask, I give them these general ranges and I say on average, people start to notice improvements in the first couple weeks after surgery. Most people with bone pain notice improvements immediately, but there's a caveat there. So a lot of people with bone pain will notice an improvement the day of surgery, right? They wake up and the bone pain is gone. It's like a miracle. However, a small percentage of those patients will then have the bone pain return in the weeks after surgery as bone remodeling is occurring. At least that's kind of the theory, is that it's from bone remodeling. So the initial relief of pain is because the PTH levels drop immediately. So the PTH stops kind of activating the bone and you feel that relief. But then over time, your bones have to then build back up and remodel, and that itself can also cause some pain. So if you're still experiencing bone pain, it's likely bone remodeling. And unfortunately, I can't give you a timeline. For most people, it gets better in the months after surgery. But I can't say that it's not going to get better after 7 months. It probably will, especially with bone pain. Now, if it's in a certain area, then I would look into possible other causes. make sure that there's not something else going on, that you don't have, another issue there. But if you can't find any other issues, then I would assume it's bone remodeling and that it is going to get better. And during that time, I just recommend that you take the bone drugs, like calcium, vitamin D, magnesium, add vitamin K if you're not taking it, K2 if you're not taking it, because it might help. So all of those things, and then give it more time. Unfortunately, I can't give you a time frame. Cindy asks, what's the longest you've seen longest time seen to take for remaining parathyroid glands to wake up? Yeah, so after surgery, we kind of, we expect the parathyroid glands to wake up. For most people, they are going to be hypoparathyroid for a certain amount of time after surgery. So your remaining parathyroid glands, they don't work immediately. They're not capable of it. They've been suppressed. They're asleep. They're not doing their job. Right? In the first weeks after surgery, most of the time, most people will have their parathyroid glands wake up appropriately, start making hormone, and function normally in that first few weeks. I typically, and sometimes actually they overcorrect, so the calcium level drops after surgery, and then the PTH drop. Well, the PTH drops immediately, then the calcium drops, then the PTH responds and it shoots up, and you get high PTH temporarily, and then it kind of evens out. That's why I check labs around 6 weeks post-op, because by that point things have sort of evened out. I usually will see a normal calcium and a normal PTH at that point, but not always. Sometimes it does take longer. We give it 6 months to a year to get better. Now, if your PTH is 0 after surgery, and it's 0 a week after surgery, and it's 0 a week later, and 0 a week after that, it's pretty unlikely that it's going to come back. But that's not the most common scenario, fortunately. The more common scenario is that you'll have a PTH level that is a little bit low or low normal, and it's just not appropriate for your calcium. So your calcium is 8.5, but your PTH is 15. It could be normal, but not for a calcium of 8.5. So if you're seeing that, then there is a chance that those remaining glands or gland are alive. I mean, they're alive. They're making some PTH, right? And over time, they can bulk up, make more PTH, and start working to fully regulate your calcium. That can take up to a year. So that's why we don't really call it permanent hypoparathyroidism until it's been there a year. We used to say 6 months, now a year, because we do have cases where it takes that long. After a year, it's pretty much not going to happen. Probably your PTH level, if you do still have some PTH, the parathyroid glands will grow over time. So even after that first year, they can continue to grow and make more PTH. But it's slow at that point. And again, if your PTH is 0, and I mean 0, persistently after surgery, then you kind of know you don't really need to wait that 6 months. Pretty soon after that it's not coming back. It can be 0 right after surgery, and that's okay, or 0 the next day. But if it's 0 6 weeks out, that they're probably not going to come back. Okay, Mary asks, how long is the surgery for 3 glands? I can't believe I went past 7. I thought it would be 6, 7. But anyway, how long is the surgery for 3 glands? Okay, so it's kind of the same amount of time. So I do a 4-gland operation in everybody. So it's the same. If I go in and I find hyperplasia, it actually does take a little bit longer, but the reason is that I am looking at the glands multiple times. And when I look at glands, I'm always looking at them from the opposite side of the patient. So if I'm looking at, or of the glands, so if I'm looking at the left side of parathyroid glands, I'm standing on the right side. And then to look at the right side of glands, I move around the table to the other side. And I do this multiple times. And if you have hyperplasia, I do this multiple times, right? I'm really get my steps in that day, because I will look at them and say, okay, well, that one looks okay. That one I might be able to save. That one I can't save. Then I go to the other side. I'm like, all right, well, that one looks good. So I do this to ensure that I'm giving you the best chance of having a surviving gland and getting out the worst ones. But it does mean that it adds a little bit of time, because I'm walking back and forth. I will stare at them basically, and kind of dissect around, see what I can safely leave. And I do that again just to make sure that I'm not rushing into it. You don't want your surgeon to just remove the first gland he sees and then keep removing glands. You really don't want that. You want to find all four, assess them again, assess them one more time, then decide what needs to come out. Okay, but it's not that much longer. These operations, whether you do one gland or 3.5 glands, we're talking under an hour, more like 30 minutes to 40 minutes probably. Okay. Cindy says, are there drugs that can cause adenomas to form and that should be avoided if we have a tendency to form adenomas? Not really, no. The only thing that you would want to avoid after surgery to not stimulate the parathyroid glands would be to let the calcium stay really low, because that could stimulate them. But again, not necessarily to form an adenoma, but to form hyperplasia. Again, though, as I mentioned earlier, that would take a really long time for that to happen. But there aren't any drugs that, per se, well, okay, there is one. There is one, sorry. Lithium. Lithium causes parathyroid tumors. It is the exception. So when you're thinking of kind of common medications, drugs, most of them are not going to affect the parathyroid glands at all, but lithium is the big standout. It will cause parathyroid tumors. If you have primary hyperparathyroidism and you're on lithium, I usually talk about possibly stopping the lithium because we know that it will increase your risk of recurrence. Beyond that, really nothing. But yeah, lithium's the one thing to avoid if you can. How difficult is a re-op? We'll talk about that. We'll talk about that in a couple of months when we go over the operation. It really varies. Re-operations are one of my favorite topics, after vitamin D, of course. And so I will spend a lot of time talking about that. But the answer is that sometimes it's really difficult, sometimes it's not difficult at all, sometimes it's actually pretty easy. So yeah, but that's the story. You often don't know till you get in there how difficult the scar tissue is going to be. But okay, so I got to the end. We're just a few minutes after 7, and I will let everybody go, and I will see you next month. If you have questions, let me know when I post. It's hard to kind of see the questions in this chat afterwards, but if I post on YouTube, definitely ask questions there, or during the next talk next month. All right, everybody, good evening. Have a good night.